Hello everyone. Today we are going to talk about using biochemical markers to screen for gestational diabetes mellitus. Gestational diabetes is a diabetic condition that occurs during pregnancy. GDM is the fastest growing type of diabetes in Australia, affecting thousands of pregnant women. Between 12% and 14% of pregnant women will develop GDM. All pregnant women should be tested for gestational diabetes at 24 to 28 weeks of pregnancy. Women who have risk factors for gestational diabetes should be tested earlier in their pregnancy.
Insulin resistance and hyperinsulinemia are often seen in pregnancy, especially in the later stages, and can lead to the development of diabetes. Women diagnosed with GDM develop chronic hyperglycemia during gestation, during the pancreatic beta cell dysfunction, along with chronic insulin resistance. GDM is quite important in diagnosing as its impact carries a greater risk for both the mother and child in developing T2DM later in life. GDM is most commonly diagnosed from the results of an oral glucose tolerance test. This is when 75 grams of glucose is orally administered and glucose level of the individual is taken periodically. At the time of injection, 1 hour elapsed and 2 hours elapsed. The accepted threshold for a healthy individual is smaller than 5.1 millimole per liter at fasting, smaller than 10.0 millimole per liter at 1 hour, and smaller than 8.5 millimole per liter at 2 hours. However, there has been discrepancies in the reliability of this criteria since their endorsement as most effective diagnostic tool. For GDM by International Association of Diabetes and Pregnancy Study Groups, IADPSG, in 2010, as another study found that just 40% of individuals with GDM have a glucose level above 5.1 millimole per liter, and thus would have been diagnosed. This exemplified the need of an updated and reliable diagnostic markers for GDM.
In order to effectively manage and diagnose patients with gestational diabetes, blood lipid level has been a useful test, since pregnancy adds the effect of diabetes to atherogenic lipid profile development. In this experiment done by Solbia et al. 2019, they hypothesized that biochemical analysis of serum from pregnant women with GDM would provide greater insight into the pathogenesis of the disease and possibly discover new biomarkers.
This experiment aims to study the predictive role of the lipid profile in the development of GDM, as well as study the association of inflammatory markers in the patients with high risk of developing GDM. In this study, 300 pregnant women participated. 176 had positive familial background of GDM, whilst 124 did not. These women were located at different hospitals in Lahore, Pakistan, and they were first involved in the experiment at their first antenatal visit during the second trimester of their pregnancy. The purpose of this study was explained to each individual, and they all gave informed consent. They were tested for GDM in the early and late stages of their pregnancies. Each individual had to answer questions about parity, whether they have had other pregnancies and if they went to full term, their history of previous maternal diabetes or family history of type 2 diabetes mellitus, and whether or not they've smoked. Each woman had their BMI measured and systolic and diastolic blood pressure recorded. This questionnaire allowed researchers to include or exclude individuals based on certain criteria. The main inclusion data depended on family history of gestational diabetes or type 2 diabetes mellitus, a maternal age between 18 and 40, a glycated hemoglobin of under 6.5%. The exclusion data was centered around previous medical histories that may affect hormones or glucose absorption and concentration. Therefore, individuals with a prior history of gestational diabetes and type 2 diabetes, multiple pregnancies, ectopic pregnancies, and hypertension were also excluded. Also, individuals who had a history of smoking and alcohol abuse were also excluded. Any participant with a glycated hemoglobin of over 6.5% or fasting glycemia of over 110 milligrams per deciliter were also excluded. The methods of the experiment had three main areas: blood sampling, sample analysis, and data analysis. The first step was sampling the blood from each eligible participant. This was achieved through venipuncture. Each subject gave blood between 14 and 18 weeks. Glucose levels greater than or equal to 5.1 millimoles per litre, whilst fasting 10 millimoles per litre at 1 hour post-load or 8.5 millimoles per litre at 2 hours post-load were diagnosed with GDM. After the glycemia and routine pathology tests, 5 millilitres of blood was drawn from the subjects and the serum separated by centrifuge. These samples are then sent for analysis. They were brought to room temperature, then the levels of total cholesterol, triglycerides, LDL cholesterol, and HDL cholesterol were analysed through a clinical chemistry analyzer, whilst the levels of hs-CRP protein was determined through an ELISA kit in flow cytometry. The next step is data analysis. Statistical analysis was done by one-way ANOVA. A comparison of the results was done through SPS PROC-GLM in SAS software. Out of the data produced, p-values less than 0.05 were considered statistically significant.
From that data analysis, we get the level of total serum cholesterol, low-density lipoprotein, LDL, very low-density lipoproteins, VLDL, and hs-CRP. Firstly, the TC levels obtained within this investigation begin to illustrate the statistically significant changes that individuals who develop GDM experience. It was found that the increase in TC was incredibly statistically significant, where P equals less than 0.00086 plus or minus 2.39 milligrams per deciliter, whilst the control level was 340.43 plus or minus 1.56 milligrams per deciliter most notably. The TG level 2 experienced increase at both testing individuals and again experienced its most significant increase in the third trimester, where GDM affected individuals averaged at 450.45 plus or minus 4.21 milligrams per deciliter, whilst the control level was, at average, 423.94 plus or minus 338 milligrams per deciliter. Continuing, the HDL level recorded was also incredibly statistically significant, however decreased, and most significantly occurred in the second trimester. As the GDM group recorded an average of 45.71 plus or minus 0.74 milligrams per deciliter, and the control group averaged at 59.80 plus or minus 0.78 milligrams per deciliter. The LDL level also experienced an incredibly statistical significant change as it increased in the third trimester, with the GDM effective group averaging 227.13 plus or minus 3.43 milligrams per deciliter, and the control group averaged 201.60 plus or minus 2.75 milligrams per deciliter. The VLDL also increased at incredible statistical significance at 53.38 plus or minus 1.11 milligrams per deciliter for the GDM effective group,
and 47.38 plus or minus 0.48 milligrams per deciliter for the control group. The level of hs-CRP increased to 9.86 plus or minus 0.37 milligrams per deciliter for the GDM effective group and 7.27 plus or minus 0.53 milligrams per liter for the control, which was deemed to also be incredibly statistically significant. The participants whom were positive for GDM were also screened of their family history of GDM, and thus the investigation was able to conclude the increase or decrease of the parameters tested by positive or negative family history. It was found that GDM occurs in individuals with a positive family history at 32%, which is significantly higher than individuals with a negative family history, which only occurs at 14% of cases. All parameters show its most significant increase in the third trimester except HDL, which decreased most significantly in the second trimester.
Any individuals who developed other clinical complications throughout the course of this investigation have been excluded from the results. This is to ensure that any statistically significant changes detected are solely attributed to the development of GDM within these patients.
From the results gathered, it can be concluded that the significantly lower level of HDL in early second trimester is the best indication for the development of GDM.
Furthermore, the article discusses the idea that females whom develop GDM have an increased risk of inflammatory health hazards seen as early as in the late first trimester, once again exemplifying the need for an early diagnostic tool such as low HDL levels to ensure the prompt and safe treatment of GDM to limit effects such as uterohyperinsulinemia in offspring.
Individuals with a positive family history of GDM should undergo diagnostic testings for GDM early in pregnancy, as they are more than twice as likely to develop GDM than an individual with a negative family history. The elevated levels of estrogen trigger the synthesis of TG and VLDL. This leads to an increase in TC and TG. This is incredibly important to diagnose as early as extended periods with no treatment can lead to a cardiometabolic effect occurring in offspring. The level of VLDL increases as TG increases, as VLDL is synthesized from TG in the liver, thus as TG increases, as does VLDL. From this increased level of VLDL, the level of LDL must also increase, as VLDL combines to form LDL. LDL is the main form of transportation of TG in blood. Thus, as there is more TG, this synthesizes more VLDL, which allows the formation of more LDL to transport the initial increased amount of TG. The increased level of TC, TG, and LDL in GDM is due to the increased storage of progesterone and fat in the early second trimester. This is to reset the lipostat in the hypothalamus after alteration during pregnancy. hs-CRP increased by 69% in the GDM effective group in the third trimester when compared to the control. hs-CRP works as an effective inflammatory marker. An increase in hs-CRP in the serum is a largely responsive indicator on systemic inflammation, a health hazard which is autonomous with cardiovascular diseases and type 2 diabetes. Significant increase in hs-CRP levels supports the hypothesized positive association between inflammation and hyperglycemia, as the increased level of hs-CRP found indicates inflammation present in the hypoglycemic GDM-affected individuals.
In an effort towards assessing the limitations, validity, and accuracy within our chosen paper, a variety of other papers researching and reviewing the diagnostic criteria and suitability of various biochemical markers was selected and reviewed. From this, a consensus on the great usefulness of both HDL and hs-CRP as a diagnostic marker for GDM was discussed. Firstly, Dreyer and Dupis, 2017, states that a decreased level of HDL at the first trimester is predictive of later development of GDM. This greatly correlates with the results found and conclusions drawn from our selected journal, as the significantly decreased level of HDL early second trimester functions well as a diagnostic tool for developed GDM. Continuing from this, as Dreyer and Dupis concluded, HDL also functions as a diagnostic tool prior to the development of GDM. The research gathered from our selected journal is limited in its assessment of the behaviour of the lipids tested prior to the onset of GDM. Next, Schaus et al. 2018 examines the relationship between hsCRP increase, and thus the presence of inflammation, and the development of insulin resistance. They found that an increase in hsCRP in the second and third trimester of pregnancy changes with great reliability during the onset of GDM, however noted that only functions well as a diagnostic tool in the absence of any other acute or chronic inflammatory conditions. As the article we selected has removed individuals who develop other inflammatory conditions throughout the duration of the investigation, the results of the hsCRP level does in fact indicate there is a strong relationship between inflammation and insulin resistance, but it cannot be accurately and reliably used as a diagnostic tool for individuals at risk of developing GDM due to interference from other forms of inflammatory conditions. Xiao et al. 2018 too found that a decreased level of HDL in the early second trimester is an accurate and reliable diagnostic tool for individuals both prior and after the onset of GDM, as the decrease in HDL occurs early enough in pregnancy at a significant detectable change and is uninfluenced by other diseases or conditions.
In comparison with the control group, higher levels of TG, TC, LDL, and VLDL were found in subjects who developed GDM in early and mid-pregnancy. Therefore, these high levels in the early second trimester can be considered a strong predictor of GDM in the later stage of pregnancy. The result of this study also suggests that hsCRP is a powerful pathogenic factor in the occurrence of GDM. Similarly, low levels of HDL in early gestation can be used as an indicator of GDM in a late pregnancy. Because a clinical history of GDM is associated with a predisposition to T2DM and other metabolic dysfunction, screening for such dyslipidemia and inflammatory markers in early pregnancy can significantly reduce the chance of GDM occurrence, improve treatment outcomes, and reduce complications.